We're going to position today's session. There's a lot of information to go through with this report, so we're going to try and do this in as entertaining a way as we possibly can do, in an engaging way. I think entertaining might be a bit of a challenge for us, but we do appreciate there's a lot to go through, so we're going to try and keep it moving along at a pace. We have invited 2 or 3 people to act as discussers, people that we know, just so we come to the first hour and have a little bit of a breather, just stretch of legs, maybe another cup of coffee. The discussants that we've invited today are Evelina, that I referred to earlier, Bernie Hollywood, and we'll do an introduction to Bernie and his incredible boat of hope then as well. And Debbie as well is on cue, but Debbie has got a work commitment tonight with a new person joining her team, and she may have to drop off after about the first hour, not drop off to sleep, but drop off from the call. So we may have a chance to speak to Debbie, possibly not. We'll just see how that goes. But just a final word on the chat. Please do leave any comments in the chat facility. If you can't see the chat on the black bar there, go to the More menu with the 3 dots. Q&A for any specific questions that you've got, and we'll try and get to those and refer to them. But thank you for joining us for this presentation of the Jordan Legacies Action Research Project and Report, Moving Towards a Zero Suicide Society, a Practical Vision. We're going to brief really you on this action research, and also the Suicide Prevention Act proposals that we petitioned to government as well will form the latter part of today's presentation, and get some of the questions answered for you there as well. But first of all, just very brief introductions from Paul and myself, if this is the first time that you've come across us, hopefully not the last. My background was as a founder and director, of course, of the Jordan Legacy. That's what I do now. But in my previous career, I was a former leadership and management consultant and trainer, and director of a leadership and management training company. And more recently, for 11 years, I worked as a social media consultant for my own business, Linked to Success. Now, as a speaker, workshop facilitator, and suicide prevention advocate, I've co-authored this report with Paul. And ultimately, I suppose if I had to attach a label of any kind to me, I am, of course, Jordan's father, and we'll be talking a little bit more about that in a moment. But before then, I'll just hand over to Paul to provide a bit of background about himself.
Yeah, thanks, Steve. Just picking off some particularly relevant parts from my CV. I've got a research background. I'm a researcher by background. I'm a research fellow. So obviously I bring my research skills and experience to this particular project and all the work we do in suicide prevention. I was formerly CEO of a research-based consulting firm, which grew very quickly from 5 to 50 people, and was regarded as incredibly successful, although it gave me burnout. So depends how you define success. Background as an executive coach, also trained as a counsellor when I was in Australia, and generally as a kind of facilitator. 10 years working, just over 10 years working in suicide prevention, 20 years living with mental illness, co-author of this report with Steve. And Steve often describes me as his right-hand man, so I decided to start owning that one.
Yeah, I think when we officially bring you into the Jordan Legacy full-time, which you are full-time, Paul, but in an official sense, we'll have to give you a proper title.
Proper title, yeah.
Yeah, Steve's right-hand man doesn't look quite right on a LinkedIn profile, I don't think. So let's just talk a little bit about the structure of the session. As I say, we're going to run through till 8:30 at the latest. You'll be pleased to hear that we ran this session last week and did finish slightly early. In a moment, I'll share and re-emphasize our why, but of course you will have your own reasons for being here and your own why, and we've seen some of those. And some of those, of course, are that you would have been impacted by suicide in some way. So we want to present to you the report, give you a bit of background behind that report, how it came about, and open up and allow opportunities for Q&A and discussion and chat as much as we can do through the session today. We will also brief you on the Suicide Prevention Act. Why have we created this petition? What is it looking to achieve? We often hear that government must do more. Well, we have hopefully, through the collaboration of others, defined what the government should be doing. So we're going to take a look at that later. And we'll finish off with next steps, really, including how you can help as well. Now, my journey, I think, will be known to to many of you, but just to re-emphasize that I mentioned that my background was as a social media consultant running my own consultancy business. And in fact, on December the 4th of 2019, that's exactly what I was doing. In fact, I was delivering a Facebook workshop to a large automotive group in the Midlands at the time. When I got a call from my son Jordan's partner and girlfriend, Charlotte, with the devastating news that Jordan had taken his own life. The photograph that I share here is, I think, poignant for lots of reasons. It was one of 2 times that I got to see Jordan before he died, and this particular experience and evening was on October the 7th of 2019. So we're talking just really about 8 weeks before he took his own life. And we were going out to watch one of his favourite bands, or our favourite bands in Leeds, Hootie and the Blowfish, and stumbled across a couple of burgers and fries at a table in a bar in Leeds before we walked around the corner to the event. And we all look at these kind of photographs, don't we? But we look, the waitress is taking the photograph, we look at the smile on Jordan's face, we look at the smile on my face. And, if we could have had speech bubbles maybe between us at that point, I wonder what those speech bubbles would be saying in terms of thoughts there. So it's quite a poignant photograph for me. But this is our why. This is why we founded the Jordan legacy, and why we are so passionate really about trying to ensure that other families don't have to go through the experience in the future that we have done. Paul, I'm going to hand over to you at this point now to start to take us through the report, and obviously at any point you want to cue me in as before, please do. But yeah, over to you.
Okay, thanks, Steve. Yeah, well, it's worth us just going through this kind of story in terms of the end of 2022. Steve and I got together. We've been involved in so much. We've been doing so much through the Jordan legacy with just a very, very small team of 3 of us, but doing a lot of collaborative work with other people wherever possible. And we wanted to review what we did. We wanted to look at what we wanted to do in 2023. And when we looked at what we'd done, the articles, the posts, the events, the workshops, we helped to get more people through mental health first aid training, and we have follow-up support sessions for those after they've done the training, because it can be a lonely place going back to the workplace after you've done the training, especially if you're the only mental health first aider there. So we have those follow-up peer support sessions, all the advocacy and campaigning, meeting up with Department of Health and Social Care on a regular basis. For instance, Steve and I involved with Mike McCarthy and Ian McClure in co-creating the Baton of Hope, and then co-founding the Baton of Hope, and everything that was involved in that. And also launching Jordan Space, our radio show, which is, as far as we're aware, the only fortnightly radio show which is focused on suicide prevention and provides a platform for people with lived experience. And we've had a lot of different lived experiences on that show, and we'll have many, many more to come. And it will be even more diverse and inclusive by the time we've got a couple of years down the track. But our primary concern was that the suicide numbers in the UK, the suicide numbers in England and Wales were not coming down. And it's sometimes hard to stay hopeful and hard to stay positive, especially when you've worked in suicide prevention for a long time. And I know that many people have worked in suicide prevention for a very long time, 10 years for me, and even sort of with 3 years for Steve, you start to think, the numbers don't seem to be going down. And some people seem to be able to cope with that by saying the numbers aren't going up, but we all have our own coping mechanisms there. But we wanted to get those numbers down. That's why we exist. That's our primary purpose as the Jordan legacy, to get the suicide numbers down. So we decided to focus on an action research project and bring all those skills to bear here and get lots of people involved, all the people that we liaise with, suicide prevention leads, people with lived experience, people from different charities, people from government, people from business, and just get the views of everybody on how can we reduce the numbers of suicides. And we set out a definition of a zero suicide society, which we'll have in a minute. And we also launched a new strategy, a new website for the Jordan legacy.
Sorry, Paul, just trying to press the buttons there, but there we go.
So back in January 2023, we thought we'd have an initial definition to start a conversation around. And we said a zero suicide society, because we're conscious that zero suicide has various connotations, and people sometimes have an issue with zero suicide, which we explored in depth in the research. But we put this definition out there: a society that is willing and able to do all it can to prevent all preventable suicides, recognizing that not all suicides are preventable, And you have to be more than willing, you have to be able to do all you can as a society to prevent all preventable suicide. So that's what we started with and followed that through in the research. But the research, what we did was focus on the key question there at the top. Every single interview started with key questions around that fundamental question, and every other question through the survey was a variation on that theme. So it was, how can we significantly reduce the number of suicides in the UK from the 6,000 plus per annum level it's been for the past 15 years, stuck at that level? And we deliberately put significantly in there. We can sort of define, people can have different views on what that is, but significantly reduce them. And also, as a supplementary, how far can we go? And I suppose you could say there's a kind of another variation of that, which is how fast can we go in getting these numbers down? So every other question was a variant in terms of what can government do? What can, starts with what we can do. What can government do? NHS, schools, workplaces, charities, community organisations, etc. What can technology do to help transform the situation with regard to getting numbers down or applications of technology? We wanted to look at what works, because there's so much evidence there and so many people have so many views, and lots of individual projects and initiatives which appear to work in getting numbers down, but don't seem to be getting numbers down at the macro level. So we also have to address the question, what do we need to do differently? And what can we do differently? Because in any other walk of life, in any other area of business, if your objective was to get the numbers on a downward trend towards zero and it was stuck at 6,000 plus per annum, whatever that was, you'd be saying, we need to do something differently. You wouldn't carry on doing the same thing. You'd be looking to do something differently. So we wanted to have that in there. We wanted to focus on evidence, as indeed many people do in suicide prevention, and it makes perfect sense to look at all the evidence. But again, how far does that take you? We wanted to look at experience-based actions and views, especially lived experience, which we'll keep emphasising. And we wanted to look at new ideas worth trying or testing, because at the end of the day, every established evidence-based action that has been researched and evaluated thoroughly has to start at some point as a new idea. And we should always welcome new ideas, and we should also welcome that in our ethical debates. So when people say, oh, I'm not sure about doing this, our ethical debate should be around this action could potentially save lives. What are the ethics of not doing it? That's the way we should be thinking about this. And we also wanted to have collaboration. Everybody we'd spoken to in our interviews were collaborative people, and they saw collaboration as the future. Collaboration is the way of getting the numbers down. So we wanted to actually look at collaboration in our research. We wanted to look at the language that people use, what is inclusive language, what pushes people away, what should we be using in campaigning, what helps, what harms, and also who should we be listening to. So the research that we did drew from lots of different sources, all our conversations over the past 3 years, all the research that we've done ourselves and commissioned, and in our partnership with MEL Research, which is ongoing, and they do work for us pro bono. So big shout out to MEL Research, who are absolutely fantastic. I'm Jen's here from Market Research Benevolent Association this evening. I know that MEL are a great partner for the Market Research Benevolent Association. The many papers, articles, and books we've read, and all the different lived experience journeys that we've been privileged to hear, all our workshops, all our peer support sessions, all our conferences, all our events, we literally took everything. We listened back to the recordings of our panel discussions on a whole range of topics: safe spaces and retreats, designing out suicide, technology, the role of education and training, children and young people. We've done panel events on all of these things, so we drew from all of those. But we also specifically, and also from the radio show, where again, we've got so much material there. It's on the website, it's a resource. It can be used in training. You could do a training session where you say, let's listen to an episode of Jordan's Space and have a discussion about it afterwards. So we use all those sources, Steve.
Sorry if I look slightly distracted, Paul. A couple of people having a struggle to get online, so I'm just kind of trying to facilitate that as well. Right. So do give me a nod if I'm distracted. Yeah, okay, Steve, get on with your troubleshooting, that's good. But we also had this specific action research project where we did semi-structured interviews with all of these people that I mentioned earlier. And also we made it an open invitation for anybody who wanted to be interviewed. And it's still an open invitation for anybody
We're having more kind of informal conversations at the moment, and hundreds of them, but we'll get back to doing some more semi-structured interviews in the next phase of the Action Research Project, which will continue until the end of 2024. And we wanted to hear different life journeys. We wanted to get recommendations from people. So every time we interviewed somebody, we asked, who else do you think we should be interviewing? Where else should we be looking? What are the sources? Any new ideas you're aware of? And we do plan more events like this, our Hope for Life conference in December, more research, more listening, more learning. When we got to the first report, we had all of this data, and we could have presented it in so many different ways. So we thought about what would be the best way to present it and what would not be the best way to present it in order to have impact, to provide insight, but also particularly to have impact. And what we didn't do, some of the things we didn't do, was we didn't just pack it full of data, because we find, and we picked this up from our interviews with people, when you do a report full of statistics, people start just arguing about the statistics. People get bogged down in the statistics and argue about the reliability and validity of the statistics and the sample size. And you can go around in circles there. Also, we didn't want to just list the actions, because we thought if we list the actions, again, we know this from the dynamics of the way the suicide prevention world works, everybody starts arguing about priorities, and it's a bun fight. So you say, oh, that's the most important action. No, that's the most important action. No, this is the most important action. And you don't go forwards, and you actually start getting competitive rather than collaborative. So we thought what might be a really good way of presenting this is to take our discussions about what Zero Suicide Society is and map it out in terms of all those practical actions as a practical desired state, a practical vision of the future, what the world would look like if we had a Zero Suicide Society. And this is not a utopian dream, although some people have read the report and said, oh, that thing in section 3.3, I think is a little bit idealistic. But 99% of it, the feedback we're getting is, yeah, that's all achievable. It's a realistically achievable desired state future. And that's what we're trying to get to. And that makes it insightful, but it also really makes it inspiring. So we took that definition that we started with, a society that is willing and able to do all it can to prevent all preventable suicides. And we basically expanded that into enormous detail so everybody can actually see it. Next. So we did have a discussion about the terminology, zero suicide. Sometimes, again, we get the pushback on that. The main pushback we get, and the main thing we need to be sensitive about, is that this is not just a target. And this is not a suggestion that all suicides are preventable and that at some point in the future we will get to zero nationally. That probably is a utopian dream, and it isn't necessarily helpful. You can get to zero locally, you can get to zero, it's proven you can get to zero in a school, in an individual school or an individual hospital or an individual area. But suggesting that you can get to zero nationally, you just start to get pushback from people. So it becomes exclusive language rather than inclusive language. So we wanted to be careful about that. And also we wanted to emphasize that zero suicide with a capital Z and a capital S emerged out of the zero suicide in healthcare movement that came out of Detroit in the year 2000, where they implemented a zero suicide philosophy and framework and a continuous improvement approach, which did actually get the numbers down to zero. And so we've got to learn from that. And that framework exists, and any healthcare organization can apply it. And different versions of it being created, a community health toolkit, which can be expanded into any area, any community, any educational institution. The framework exists there to help us get the numbers down towards zero. This issue about not all suicides are preventable, we do need to be really careful about this, because it's one of the most upsetting things for people with lived experience and people who've lost loved ones to hear people saying all suicides are preventable. Now, campaigners will say suicide is preventable, which is slightly different. Suicide is preventable as far as they're concerned is evidence-based, because in many cases it is. And we tested that. When we actually put it to people, most suicides are preventable, 100% agreement. All the academics, all the people with lived experience, all the people, all the clinicians, all of the people working in charities said, yeah, most suicides are preventable. And that's a fact, that's evidence-based. So saying most suicides are preventable gets everybody pointed in the same direction. Saying all suicides are preventable loses lots of people and upsets lots of people. So let's not do that. Some people will still take their own lives, because of just serious mental illness, and some people are in unlivable pain, and they will see suicide as a route to ending their pain. And the question just popped up there in front of me. So our use of a zero suicide society, just going back briefly, Steve, our use of the term zero suicide society is very specific. And again, we're putting in inverted commas there, and we are trying to define what a zero suicide society would look like as we defined it here. Thanks, Steve. We had this discussion about how far can we go, which was a very interesting discussion, because what tends to happen is at the beginning of the interview, you say, how far can we go? And a lot of the responses are very emotional, visceral responses. We must reduce the numbers. That's the thing we hear more than anything. We must reduce the numbers. Now, that's different to how can we reduce the numbers, which gets into more of a left brain exercise. And some people go blank at that point and they really struggle. Other people pour out suggestions. Some people have been thinking about this for years, or they've been thinking about it for the last few months deeply. And they think, yeah, I can think of a dozen specific practical actions we can take, which will get the numbers down. So we listened to all of that. We had lots of people saying we must be ambitious, but they get conservative when you start getting into targets. We have this 10% reduction in 5 years problem. This is an institutional problem. When the World Health Organization in 2014-15 urged every country in the world to set a target for reducing suicides and asked every country in the world to aim for a minimum 10% reduction in 5 years, guess what? There was only 2 countries in the world that aspired to more than 10%. Everybody went for the bottom of the range. So we have an institutional problem, and we've had it in this country as well with previous national suicide prevention strategies and quite a few of the regional and local strategies. So we need to get past these kinds of barriers. In reality, what's going on with the dynamics here is there's nobody who wants to be accountable for national targets because they don't feel they can influence the national numbers. Nobody's going to put their hand up and say, yeah, I'll take responsibility for that. Because you want to have a degree of control over anything where you're associating yourself with a target or taking responsibility for a target. But the dynamics are this, and I can see Rob already putting stuff in there. Thank you, Rob, about the Detroit Health case study, which we should all be across in detail because it is so inspiring. But the dynamics of this are quite simple. At the national level, nobody thinks they can achieve anywhere near zero. So they set 10% in 5 years as a target. But at the micro level, everybody says we should be aspiring to zero. So if you have a zero suicide plan for your school, for your hospital, for your workplace, for your local community, all of those micro zeros add up to a macro zero. And that is how we will get the numbers down. One of the reasons why we get the numbers down. I've studied the dynamics of change for many years in my professional career and done lectures at business schools on this. And the 3 key dynamics of change: the push effect, which is where our dissatisfaction with the current state pushes us away from where we are. And the numbers of suicides at an unacceptable and preventable level is a massive push factor, which applies in all of our work. But you also need a pull effect. You need that inspiring shared vision of what the future can look like to pull you towards it. And that's hopefully what our report provides. And you need an engagement effect. That's the 3rd key dynamic of change. You need to involve people in the process of moving towards whatever it is you're trying to move towards, in this case, a zero suicide society. And the problem with a lot of the work that we do, and we heard this in a lot of the interviews, there's some people who've thought about this very deeply and studied this for years. One of the problems with a lot of the work we do is in suicide prevention is it's almost all push effect. It's almost all dissatisfaction with the status quo and must do something without necessarily, and plans and things, ideas coming into it, but without that powerful pull effect, and sometimes very little engagement effect. It's only in recent years that involving people with lived experience has become a thing. It's still relatively new. I joined the very first ever lived experience panel in Sydney, in Australia, in 2014. It's less than 10 years ago that we had the first. And in the UK, it's, 2018 or 2019 or something? I think Rosemary will correct me if I'm wrong on that in terms of NSPA setting up a lived experience panel here. It might be in 2020. I think it was actually 2020. Here.
Yeah, well, I was going to say, Paul, it was later than that. Definitely.
Yeah, 2020 here. Yeah. So this is still new. This is still new stuff. And if you think about the National Suicide Prevention Strategy, which we're still waiting for, it's been delayed for a year, and hopefully we're going to see it coming out, maybe even on World Suicide Prevention Day this year. But when you analyse the past two national suicide prevention strategies, and we had lots of comments on this from the people that we interviewed, they tend to be top-down. They tend to be a government strategy rather than a society strategy. They're not whole of society. And have tended to come through the Department of Health and Social Care rather than being whole of government. So you've got two problems there. They also don't have that pull effect that you need in terms of a very clearly articulated vision of where we're trying to get to. So people are stuck in the current state and trying to get out of it rather than seeing where the future desired state is. And there's very little engagement effect. I wonder how many people on this webinar tonight were involved in the process of putting the National Suicide Prevention Strategy together. I'll just leave that hanging in the air there. But yeah, we need that micro change, to get the macro change. We need to collaborate, not compete. And very importantly, and we'll come back to this throughout this webinar, it's absolutely crucial to get to zero suicides, to get towards zero suicides. Everyone is a priority for someone. At the moment, we have this priority trap. We operate in a world and within a government and in a sector where people want to have priority groups. So they want to have winners and losers. Now, that might be subconscious rather than conscious. In some cases, it is more conscious, but in some cases, it is subconscious. And it's just people naturally going about advocating for this group, that group, the other group, and having a bit of a battle over resources and competing for attention and so on. And so you're never going to get to zero. You're going to stick at that 6,000 plus level overall and just push the air around in the balloon. So we've got to find a way through this where everyone is a priority for someone. So these are the key characteristics of a zero suicide society that were identified in our research and drawing from all our panel discussions and everything we've read, et cetera, et cetera. Now, the first piece in the puzzle, if you like, is, and this is at the heart of the Detroit Zero Suicide in Healthcare framework, and it's at the heart of every transformational change program when you deconstruct it. You've got to have continuous systemic action learning, and let's call it CSAL for short. I won't try and get in the habit of saying CSAL just for short. It's when we ask people why they think we're not getting the suicide numbers down, time and time again they say we're not learning from what we know. We're not applying what we know. We don't systemically look at all the data we have in terms of audits, in terms of inquests, in terms of prevention of future deaths reports, in terms of all of this research we have. It doesn't go anywhere. You know, it's like having lots of levers and nothing's attached. And so we have to be really, really strong in saying we've got to have these systemic action learning processes. And interestingly, we've been following the brilliant sort of petitions and processes to get this in front of MPs recently from Three Dads and from the Learn Network and so on. And we've watched the evidence hearings, we've watched the debates with great interest. And all these MPs are starting to engage for the first time with suicide prevention and stand up in Parliament and say, I've lost someone to suicide and my constituents have lost someone to suicide. And that is where we're going to get MPs on board because of that lived experience themselves, more than trying to make an intellectual argument and present lots of statistics that can engage with the heart. And interestingly, we're now regularly watching MPs on the TV saying, why aren't we learning from past suicides and taking appropriate action? Well, yeah, why aren't we? So we've got to get these CSAL systems in place. Steve? Another key piece in the puzzle is we've got to have a suicide prevention educated and activated public. Everything we do needs to be based on trying to get wide and deep public awareness, knowledge and understanding through campaigns, but not just one-off campaigns, through continuous programs, through training in schools, colleges and workplace. We know that we're getting generational change. We know that people say we're now talking about mental health in a way we weren't many years ago, and we're talking about suicide in a way that we weren't. But we've got to accelerate that change and not wait for generational change to take its course, because it takes too long. We need open discussion with sensitivity and without stigma. We need to think very carefully about our campaign messages so that they help and don't harm. So, for instance, a phrase that a lot of campaigners use, which came up a lot in our discussions, was suicide doesn't discriminate. It's a term that a lot of people use. And maybe they don't think about it so much, or maybe they think about it and think, well, there are downsides to that, but I'm going to use it anyway because I think it's a good campaign slogan. But of course, saying suicide doesn't discriminate isn't factually correct, because suicide does discriminate. There are many groups that are far more likely to be at risk of suicide than other groups, and other regions in the country. The North East has twice the suicide rate of London. So clearly suicide discriminates in that sense. But when we actually say to people, what's the inclusive language? What's the language that brings people in, brings everybody to the table and doesn't push them away? And everybody agrees that saying anyone can be affected is that inclusive language. And of course, everyone can help reduce suicides. So we know that the education has to be across these multiple factors. Learning about suicide, we need people to understand all the different factors that are involved in suicide. It's not just a mental health issue. And also, we need to shift away from talking about groups at risk, because you don't prevent suicides just by looking at groups at risk. At the end of the day, it's about people, individuals in danger. And that's what we're trying to do to reduce the numbers. So yeah, we study the groups at risk, but we've got to get into the people in danger. And we can't run away from the fact that there's enormous complexity and multiple factors involved. And again, it's not just a mental health issue. There are so many factors involved. And don't run away from it because it's complex either. And be very careful in our language. Now, before I talk to that second point there, I want to be really clear about this. When I say it's not just about being kind, it is about being kind. It is absolutely about being kind. We're all going to be kinder to each other. But it's not just about being kind. These are the things that people say in the common narratives. Be kind, just have a conversation. It's just about getting mental health support. Well, clearly it isn't, because a recent project showed that probably 500 suicides a year in the UK are primarily driven by unemployment and underemployment. And we know that past recessions have increased the suicide numbers. We know that the gambling industry and pushing people in their addictions is an enormous contributor to suicides, and that's got into Parliament now. Housing and homelessness, people not having a roof over their head. Issues in the criminal justice system, tackling loneliness. I mean, nowadays we're accepting that loneliness and social isolation are key risk factors, and we've got to look at them, and some work is being done there. People are being digitally excluded, and in some areas of the country, half of those aged 65 plus not online, and yet services are all moving online and people can't get access to their GPs and things like this. Relationship breakdown, domestic abuse, all the great work done in Kent and Medway. And it's great to hear that Tim Woodhouse has got a Churchill Fellowship to study that now. Up to a third of suicides in Kent and Medway trace back to domestic abuse. And it's about having a society, a zero suicide society that is inclusive and tackling discrimination, disadvantage, and inequality. We can't get away from those factors. And some people say, oh, it's getting a bit political. Well, it's not party political. We need all party support for all of this, but you can't get around the fact that unless we tackle these factors here, we're not going to get the suicide numbers down towards zero.
Just a point, Paul, if I can just make just a thank you for everyone putting comments in the chat. It's going to be a challenge to keep up with everything there, but just to let you know that we will be saving the chat. And if my technological abilities have allowed me to do this earlier on, there should be an option for you to also download the chat as participants and attendees at the end of this session. If not, we will follow that up with an email, because there's a lot of great things being shared in the chat this evening. Thank you.
Thanks, Steve. And I'm jealous because I can't follow the chat because I'm talking, but I'll read it all later on. So next piece in the puzzle, local suicide prevention partnerships. It makes absolute sense. Everybody agrees. It makes absolute sense to have action at the local level, to have partnerships at local level. People naturally and easily come together at the local level, and it's harder at national level. And again, we can have these micro zero suicide plans. And we can implement the continuous systemic action learning CSAL at a local level. And indeed, that's what's been happening in a number of areas, partly because of some funding that was made available, partly because of the pandemic, partly because of real-time suicide surveillance data becoming available and partnerships forming naturally around that data with councils and police and health trusts and people lived experience and community organisations in the area. we started to see some fantastic work taking place in a number of pockets around the country, but it has to be systemic. It has to be statutory partnerships, well-funded statutory partnerships across the country, and liaising with a national suicide prevention office, which is the next slide. So we had a number of people who said there was different variations on this. What they said to us was, we must have a national office of some kind. We must have a national approach. We must have a cross-departmental approach. And when we explored that, the key points were it shouldn't just be driven through the Department of Health and Social Care. And that's outdated thinking. It's outdated working and functioning and planning and operating. Suicide is not just a health issue, as we've established. And so having national plans and strategies coming through the health department effectively is not the way to get the numbers down to zero. Some people even thought it should be an arm's length agency sitting slightly outside of government. So you've got this National Suicide Prevention Office, and there are some countries in the world that have something like this. And I actually posted the other day on LinkedIn, was immediately contacted by the head of the National Suicide Prevention Office in New Zealand, wanting to have a chat. So we're having a chat. And that will coordinate the whole of government and the whole of society approach. It'll be coordinating the planning, the analysis, etc., enabling necessary data sharing. Now, I say necessary, so privacy, confidentiality, and anonymity would be uppermost there, but enabling necessary data sharing in order to get the data and analysis we need to get the suicide numbers down. Critically, one of the things we need, this has been established, and this is in our petition for the Suicide Prevention Act, there have to be suicide prevention impact assessments. This is a critical practical action that is needed and will be overseen by the National Suicide Prevention Office. So imagine every bill, every new proposed piece of legislation, every policy review, every major strategic review within government has to be subject to a suicide prevention impact assessment. And that's an idea which, people in government are telling us makes perfect sense. So that seems like an obvious thing to do. The NSPO would oversee the relevant legal and regulatory frameworks, of which there are many. So again, coordination is critical here. And we'd have compliance through the Suicide Prevention Act. And also built within that would be some statutory education and training for all MPs, ministers, advisors, and civil servants. And there would also be what we've called zero harm audits. There are examples, sadly, many examples of where government policy has actually caused harm. I could list 10 in this country. I could list millions around the world. I'm exaggerating slightly, but I mean, in Australia, where I used to live, there's just been a royal commission into the robo-debt scheme, where there was a ferocious, relentless regime to recover debt, government debt, which meant welfare recipients were hounded relentlessly with emails usually and online messages and letters coming through the post. Even if they were $1 in debt. And that led to a number of suicides. And when the Royal Commission looked into it, they said not only was it bad policy, it was actually illegal. What the government was doing was illegal. And the politicians were criticised for introducing that policy, but they're also the civil servants were criticised for not standing up to the politicians, even when they're doing things that were illegal. So zero harm audits are a way of snapshotting every government policy and checking to see if they're helping or indeed if they're harming.
And just a point there, shared by Debbie Rogers here, has said that public health are typically the go-between to report local data at a national level. One of the challenges, of course, is that they're employed through local authority and wear many different hats, so their full focus can't actually be on suicide prevention. So she's saying, having a national suicide prevention office would really enhance what's out there at the moment. So thank you for that, Debbie.
Thanks, Debbie. Yeah. We're going to come on to the petition later. This is a key piece, but we're going to focus on this in more detail in the second half of this webinar, so we'll move on from there. As I mentioned earlier, everyone is a priority for someone. It has to be everyone a priority for someone. The whole world is operating in this priority trap. Now, we need to just be careful about this and nuanced about this. Inevitably, there are some organisations that exist to look after one group, and that's absolutely right. Papyrus exists to look after the needs of children and young people. And that's absolutely right. They do great work. I'm a trustee with Age UK, and I'm a member of the National Influencing and Campaigning Committee. So when I'm wearing my Age UK hat, I'm looking at the needs of older people. So that's quite right that we all do that. But we have to have a way of all coming together and saying, how do we all work together, all looking after our different priority groups, and coordinate and integrate, and have, rather than having a national suicide prevention strategy, have a coordinated national framework for coordinated action so that everyone becomes a priority for someone and nobody is losing out. And we, in our current state, we have these, some groups that have greater risk, and we've got to work out ways of becoming focused on individuals. One of the beauties of the desired state is that by definition, the closer you get to zero, the more you flatten those groups at risk, because there are no longer lots of groups that have significantly higher suicide rates. And that's when we really get into the person-centered approach and get momentum. We've got to involve people with experience. We've had so many people in our interviews and so many people at our events saying that this is at the heart of all suicide prevention approaches, all effective suicide prevention approaches. We've recently had the government's key advisor, Professor Appleby, saying that the biggest shifts that we've seen recently in suicide prevention effectiveness are coming through the involvement of lived experience, especially bereaved parents advocating for change. And that's coming from the government's key advisor on this. So it's become acknowledged and accepted, but we can do it better. We can involve people with lived experience more appropriately. We can use more ways of involving people appropriately. We can get more people involved, more diverse experiences. And the more that people open up about their experience, the more we can take that into account at the moment, because there tends to be often a pattern where there are a small number of people with experience who we hear from a lot, and then lots and lots of other people, like a pyramid, lots and lots of other people with experience that we don't hear from very much, or we don't hear from at all. So we've got to take a research and community engagement approach to this, and a participative democracy approach to this, if you like, and find better ways of involving more people with experience, and also involving all the other stakeholders that are affected by this, getting our involvement dynamic along with the push and the pull dynamic. And we've got to involve all those plans that we've talked about. Are you checking your emails, Leslie? All the plans that we...
I don't know what's going on, sorry, Paul. Some things popping up.
All the plans that we talked about, all the zero suicide plans and the suicide prevention impact assessments and everything else we've mentioned earlier has got to involve people with lived experience, or we won't get the maximum learning out of that. Now, community-centered support, I'll just say a few words on this, and then Steve, you maybe want to come in on this one, but they basically, the message we keep getting again and again and again from every interview is that we need more of a community focus rather than a secondary healthcare focus in our system. And people should be guided first through community support mechanisms, and then, if necessary, into clinical settings. Obviously, emergencies are different to that, but there's a general rule. That's how the system should be devised. Steve, you covered a lot of this in your interviews.
Yeah, I mean, a lot of the conversations we had, and this was from a lot of people working in crisis centres, and one of the interviews that really stood out for me, and many of you will be familiar with Joy Hibbins and the books that she's published, but the incredible work that she does with Suicide Crisis UK in Gloucester, I believe. I think I might say that's Gloucester. And Joy at the time set up Suicide Crisis UK as a place for people who were feeling suicidal to come to at a time where she was highly suicidal herself and really struggling with her mental health, and in fact was in hospital at the time the centre opened. One of the things that she advocates for, and why her approach and their approach at Suicide Crisis UK has been so successful, and at the time of her first book, published some 4 years in, they were still yet to lose anyone to suicide who had attended their centre, and I think that is still the case. I need some clarification on that, but huge success rate. But one of the approaches is about treating people as a whole person. We're often quick to pathologize, I think, in today's society, something that came out through a lot of our conversations, that we label people maybe too quickly, and particularly young people, with a mental health illness. People will struggle in life. They will grieve. They will face traumas of one kind or another. But there is a concern that sometimes we don't spend enough time to understand what's going on. And we say we're talking about maybe society, we're talking about the healthcare system here, that we leap to conclusions too quickly. But where the most successful cases seem to be is where people are being given the time to be properly understood and treated as a whole person rather than a mental illness. So I think that it's really important that we look at geographic communities of common interest. I'm looking at some of the chat around what about neurodivergence and other, all these different communities. Communities can be groups of people defined by the mental health illness or what is impacting on them personally. It can be geographic communities where people live. Paul, you mentioned about the Northeast before. So, a lot we can do, but also I think what's really important is we must look at all the different means of communicating and engaging. You talked about the over 65-year-olds, many of them can't access online. We've got to look at using in-person, telephone, text, online, whatever the medium mix is that works for that person, and not have, which seems to happen quite often, this almost one size fits all approach. So something I'm very passionate about, but lots more to cover. So I'm going to hand back to you.
And there's a lot more in our report. Obviously, in our report, there's loads more detail than this that we're covering tonight. And also, I'm conscious that you could, at the end of every single one of these things we've said, you could probably say, and we need more money, and we need more funding for this. We're conscious of that, but we also know from our interviews time and again, it's not just about money. It is about changing some of our systems and better using the resources that we have. On safe supported spaces, again, I'm just going to say a brief word and then Steve might want to flesh this out. But the two things that came out from safe supported spaces and places discussion is there are two categories here. One is dedicated safe and supported spaces, and there are lots of good case studies around, case examples around. But the other is trying to make all of our spaces safer, supported spaces in all environments, in all our workplaces. And Steve and I try and do this with Jordan's Space, for example, on the radio show. We've had people opening up on that show about the lived experience for the first time because they say they felt it was a safe, supported space. So it's about all environments. But Steve, you want to say a few words about dedicated, safe, supported spaces?
Yeah, I mean, we've run a number of online panel discussion events over the last 3 years, Paul. As you know, we have one very specifically around retreats and safe spaces back in 2021. And we had people like from James's Place and Maytree and Debbie with the work that she does at Sean's Place. So many great examples. But I think what we looked at with this study and the research when we started to have the conversations was that people started to open this up. I think there was a thought that a safe space might be just a place that somebody went to, a physical location that someone who was struggling with their mental health or feeling suicidal went to. But in a zero suicide society, it's much broader than that you don't have to have a diagnosed or diagnosable mental health illness to access this. What is important, though, is that this facility, this space, let's call it, has ease of access 24/7, that people know where to find such places. They could be near hospitals, they could be in urban centres, they could be in green spaces, they could be rural retreats, they can be within schools, within offices, listening cafes we're hearing a lot of now. So many ways in which safe spaces can be provided. But I think the most important point there is, let's not just assume they're for people with mental health illnesses. They're for all of us who are finding life a challenge and a struggle, to prevent those people from moving further downstream into a mental health illness of some kind.
Thanks, Steve. I'm going to go through these next few slides at a fairly quick pace because I want to get to a particular slide where we've tried to pull this all together onto one slide. That's been one of our challenges here. And we want to have a break as well, have a comfort break, and then come back and have our discussants giving their views and have questions and so on. And then we've got plenty of time later on for the Suicide Prevention Act. So I'm just going to go through these next few slides at a fairly quick pace, and then we'll have that break. So obviously we need appropriate and accessible mental health services, accessible and available and tailored to people's needs, etc. And we don't have that at the moment. So the system is broken, and we've got to have standards we put here and wait times driven down by public pressure based on reasonable expectations. We often use that in a lot of the research we do. Policy research uses the term reasonable expectations. Well, when somebody is referred into the mental health system and they're having suicidal thoughts and they need treatment or support, and they're put on a 6-month waiting list, I think we can all say that that is not that's not meeting reasonable expectations in a civilized society. So we're so far away from what we should expect. We've all got to mobilize our energies in order to challenge that. And we've had a lot of discussion recently about different types of campaigning and advocacy and being kind in our campaigning and advocacy, and we're working on that. But there are times when you just have to stand up very assertively and say, this is wrong. This is just way below what we should expect. And obviously we've talked about things like the whole the person-centered approach. Just a final point on that. I think this is worth us just emphasizing. This is in our report as well. Personalized safety planning has been a big step forward, but the risk assessment systems have taken so long to start coming out of the system. It emphasizes just how long it takes to get change. I was attending conferences 10 years ago where clinicians were saying our risk assessment systems in our health system are not only no good at predicting whether somebody will take their life or not, they're actually killing people. The systems themselves are killing people because when they come in, they're assessed as low, medium, or high risk of suicide. And if they're categorized as high risk, they usually come out of the hospital safe. If they're categorized as low risk, they don't get any support, and they're more likely to take their own lives. So the system itself is killing people. Now, I heard clinicians presenting that at conferences more than 10 years ago. It's taken us 10 years to start getting that out of the system, and it's still in there in a lot of our health organizations. So we've got to ask some serious questions about that. Next slide, Steve. We've got to have suicide prevention systematically within our health system. Again, we've talked about what can be done here. We've got to shift the power base from secondary treatment and care through to primary treatment and care through to the community. It is about a power shift. We've got to have universal adoption of the zero suicide in healthcare framework. If we've got an evidence-based framework proven in the States and in parts of Australia and in parts of the Netherlands and here in UK, in Merseycare, proven to actually reduce the numbers of suicides, why aren't we using it? Why isn't it mandatory in every single part of the health system, every single health trust? We've got to have respective supportive cultures. When we've studied the zero suicide in healthcare framework, again, in the UK and elsewhere around the world, and I worked with the person who founded the Zero Suicide Institute in Australasia, and we studied this. The main pushback is staff feeling that they're being asked to do things they can't do, and they're being asked to do things they're not funded for, and they're being put under pressure with performance targets, and they're being blamed when things go wrong. So there are reasons why staff push back on this, and there's ways around them, as we've demonstrated. And you can read Sidney Decker's books and all the rest of it. You can see all of these reasons why people push back. And Joe Rafferty, the chief executive of Merseycare Trust and one of the founders of the Zero Suicide Alliance, I used to go to his presentations. He'd say things like, when something goes wrong, we've got to, within the health service, we've got to stop saying who's to blame and at least move to what's to blame to get into constructive discussions about changing the systems. And there must be mandatory training for staff. I mean, when we actually started writing this report, Steve and I were putting down there should be mandatory training for all clinicians, managers and staff within the health service. And then we actually came across two examples of psychiatrists saying, we're not trained in suicide prevention. Psychiatrists telling us we're not trained in suicide prevention. That's a system gone completely wrong, isn't it? Next slide, Steve. Sorry, I'm getting a bit worked up about this, but there are times when you have to get a little bit worked up about this, isn't it? We know from all the research that's been done that a lot of people who take their own lives have experienced all sorts of forms of trauma and loss experiences, some of it going back to childhood and earlier life, some of it compounding a whole bunch of different types of trauma. And yet the support for people who've experienced trauma and complex trauma is often not available. And it must be available. It must just be compulsory to have some form of counselling at least offered to people in all of these different situations, because again, you're not going to get the suicide numbers down without that. Next one, Steve.
Oh, there we go.
Yeah. We also know that people with disabilities and long-term physical health issues or chronic illnesses are at increased risk of suicide. But that's not everybody. We need to be careful and not stigmatise people. It's not everybody, but some people have a significantly higher suicide risk. And again, they need wraparound care, and we've got to provide that. And it's relatively easy to provide that. These aren't people, sometimes with suicides, we know it comes out of the blue. We weren't expecting it. Somebody's taking their life. We've had this in my own family. Nobody expecting them to take their own life. There were no signs, etc. We've all experienced, lots of us have experienced that kind of thing. But there are other cases where we know somebody is experiencing all of these issues. We know they're at risk. We know that individual is in danger. We've just got to get the support around those people. And again, it's got to be a continuous systemic approach, and we need to have mandatory suicide prevention training for all the people who work with those who are at those kind of risks from disabilities and long-term chronic illnesses. Obviously, in the education system, Steve, I'll just keep rattling through this one. I know that you.
Yes, no, go.
But I'll just keep going.
Yeah,
okay.
Yeah.
a lot has been done on this. The three dads with their petition. We had an event, a panel event with the three dads, with a whole bunch of people working in education, loads of ideas, loads of practical ideas. And interestingly, we had one of the three dads at our events, and when they're asked, you know, what specifically do you want? What specifically you want to see? And their response was, we don't have a view on that. We don't actually have a view on specifically what should be done in schools. We just want suicide education within the school curriculum. We leave it to other people to, you know, talk about specifically what needs to be in there. And I think that's a really kind of healthy approach, because the three dads have managed to get lots of people around the same table agreeing with that principle, and all the different views will wash out in the system in terms of exactly what goes in place. And again, training for teachers and you know, zero suicide plans for schools. This all makes perfect sense. Workplaces, so much can be done through workplaces. We know that those people, unemployed or underemployed, have an increased suicide risk, but the vast majority of people who take their own lives each year are working age and are employed. They're working. And you know, workplaces, they spend most of their time in workplaces, and workplaces have a responsibility. And if they're smart, workplaces are a community at work, and they do look after people, because if they want to be a successful, sustainably successful business, they will have a mentally healthy and psychologically safe workplaces. But this was something we discussed with quite a number of people in some depth. And a lot of the advocacy at the moment is around individual workplaces and trying to get individual workplaces to be healthier. But we've got to look at it by sector, industry and profession, because that is the way to get the numbers down. And Steve and I have been doing a lot of work and speaking to a lot of people recently in the construction industry, and we're about to publish an article about the construction industry, and Steve's off to a golf day with big construction firms on Thursday and so on.
Yeah, not playing, I should add.
Not playing, yeah. No, he's they're sort of getting them engaged here. But the latest figures show that in England and Wales, almost 10% of all the suicides in England and Wales in 2021 were people working in the construction sector. Well, obviously, you've got to go to the construction sector and say, how can we get these numbers down? And the construction sector are doing all sorts of things to get the numbers down. There's lots more they feel they can do, and they need to have zero suicide plans, and they need to put this continuous systemic learning in place. It's not just about having lots of training courses. Sadly, a lot of them have gone down that route, and they're all competing with each other for which training course should be put in place. But it needs a systemic approach. But also, we need to say to the construction sector, this isn't just your problem, this is our problem. If we want to, as a society, get the numbers down, we've got to help you, and the government's got to help you as a sector to get those numbers down. Move on, Steve. I think it's just a couple more to go, and we're getting close to our break here. So designing out suicide. This is something that came up. I did a project with the Global Zero Suicide community through 2018 and 2019. And one of the things that came out of that from a transformational change perspective was designing in suicide prevention or designing out suicide in a whole range of different ways. And that was focused initially on restricting access to the means of suicide, which is the single biggest way of reducing the numbers of suicides. A massive study, a meta study done by Professor Jane Perkins from Melbourne University showed that by far the most effective way of reducing the number of suicides is to restrict access to the means, on a global basis. So we've got to keep looking at that. But when we actually got into this as a practical proposition, one of the key areas was using design thinking and things like business process engineering. And we started getting together with designers. We had an event again. We had a Jordan Legacy panel event on this. We've got designers, architects, engineers, etc. together, people from the railways, car park managers, etc., etc. And we talked to them about how we can design in suicide prevention or design out. And there's lots of great little case studies around the country we can learn from, but it's not been done systematically. And also we can change the building regulations, because when the building regulations were last reviewed, they were looked at from the perspective of how can you make buildings and public places safer to prevent harm from accidents. So they were focused, the mindset of the people who were writing those building regulations was, people might have accidents and maybe we can stop people having accidents. Well, how about rewriting the building regulations from the perspective, what about where people aren't having accidents, where people are actually deliberately trying to harm themselves, and just see how far we can take this in terms of getting changes. And final slide, I think this is in this section. So we're doing pretty well here before our comfort break. And we all need a comfort break now, I think, after listening to me for this long. Tech for good. A lot of the work that's been done over the past 5 or 6 years in the online area, and this hasn't moved as far as we would like it to move in the last 10 years. When I stood up at TEDx Sydney in Australia and pitched digital life-saving as an idea to the 3,000 people in the room, a lot of the work has been done around the negative aspects of online abuse and online safety. And we've got the online safety bill slowly chugging its way through Parliament. But we also need to look at, we need to maintain that work, and Ian Russell and others are doing fantastic work in that area, but we also need to focus on the positive side, tech for good. Digital life-saving initiatives, lots that can be done, improving search engines, improving virtual assistants. 10 years ago, with the sort of embryonic virtual assistants, if you typed in to the Alexa and those types of technologies back then, if you typed in, "I'm thinking of killing myself by throwing myself off a bridge," it would come back, "Here's the nearest bridge." Now we've obviously moved on from that. We've got search capture, we've got the Ripple tool, we've got a lot of stuff going on that's massively improved this and directed people to support. But there's much more that could be done, including using augmented intelligence, working with the finance sector, and we've been working with a number of people in the finance sector who can identify people in suicide danger from their financial data. Now, obviously, there's ethical issues to resolve there, but if we can identify people in suicide danger from their financial data, we should be at least looking at that as a possibility for helping to reduce the number of suicides. And then we've got, finally, last but not least, tracking for life tools. Now, these are tools where this is people known to be in danger. This is people with episodic mental illness. This is people being discharged from hospital. These are apps that, for example, help to track people home safely. It flags when people go near suicide hotspots. This is permission-based, so when people are well, they give their permission for alerts to go to loved ones or a friend. It's all very ethically done. But again, this is scratching the surface. The tech side, we really haven't even got into this. And if we're going to transform something like suicide prevention technology, just as in every other transformation that's ever existed, technology is going to be a factor. Now, let's just do these builds. If you leave that there, Steve, we'll do these builds. And what we're going to do is just put this model up, and then we're going to have a comfort break. And we're going to leave this model up on the slide for you to just have a think about if you're not dashing off to the loo or having a cup of tea or coffee. Steve and I had this challenge of how on earth can we put all of that information from the report onto slides? How can we on earth can we put all that information on the slides into one slide? But here we are, we've had a go at it. And this is going to build into a model which has 2 different concepts within it. So firstly, if you think of it like building blocks, the foundation stone to everything we do to get numbers down towards 0 is involving people with lived experience and all the key stakeholders. On top of that, there are 2 other key building blocks. One of them is this concept of everyone being a priority for someone. And we know the reality is that there's lots of competition, and somebody put in the chat it's inherently competitive. Well, we've got to challenge that or find a way through this where everybody is a priority for someone. Or we're not going to get the numbers down to 0. They'll probably stay where they are at 6,000 plus a year. We've got to have continuous systemic action learning, CSAR, as we've said. Then there's another layer, building blocks on that, which are the systems building blocks. If you just put the next line on, Steve. And these are having systemic approaches in our health system, in our education system, and within our workplaces, and having a suicide prevention educated and activated public. So we've got a really solid base there. On top of that, we've got this layer with the Suicide Prevention Act, which we're going to talk more about in the second half, and the local partnerships, the national office, and addressing the socioeconomic factors. On top of that, we've got the appropriate and accessible mental health services, we've got the safe supported spaces, we've got the community-centered support. And then on top of that, we've got another layer we've put on there with designing out tech for good, the trauma and loss support, and the support for people with long-term physical health conditions. So we've got a model here in terms of what we know the building blocks are. So if you think of it like those building blocks, and another way to think about it is to see it like a jigsaw picture or like a puzzle. So there are various pieces in the puzzle. And if we don't have some way of looking at each piece in the puzzle, we're never going to see the big picture, and we're never going to get towards our zero suicide society. And the final thing I'll just say before I have a rest, and you have a rest from my voice, is we deliberately left a missing piece in there because we're not pretending this is comprehensive. It's pretty good, but it's not comprehensive. It's a start. We're going to continue doing our research, keep getting feedback. Already at the event we had last week, we had people suggesting other pieces that could go in there. and we're listening to all of those pieces. So I suggest that we take a break there. We just take a 5-minute comfort break. We come back and just remind people of that. We've got 2 more slides just to finally summarize this, and then we're going to have our discussants. We're going to have questions. We're going to have plenty of time for the questions coming in, and then we've got plenty of time to go through in detail our petition to Parliament for Suicide Prevention Act. So this is just to make a point here that one of the things about suicide is that it is a window into society's problems, and this is something that we feel is useful in trying to get this approach, the systematic approach, and to get all the MPs cross-party on board, etc., etc. Because when we get into this, people learn some lessons that perhaps they hadn't previously thought about. That suicide prevention is a lens and a catalyst, and also suicide is a means of death, not a cause of death, right? It's in the ONS statistics as being a cause of death because that's the language that's used, but suicide is not a cause of death. Suicide is a means of death, not a cause of death. It's something else that has caused the death, right? So once you actually start getting your head around that, you start looking at, well, what are the problems? What has actually led to this? And people naturally get into that continuous systemic learning. Also, people think of suicide as a problem. When they first get involved, when MPs first get brought into the conversation, they think of suicide as a problem. And then they start to learn that for those people who are attempting to take their own lives, they see suicide as the solution to their problem. And so you have to flip this thinking and get into a different discussion. And what we're finding is that we can get politicians into discussions that they previously weren't having by using these basic dynamics that are going on here. So for instance, a politician, if you propose a universal basic income, because people in poverty are more likely to die by suicide, you propose just straight out a universal basic income, a minimum guaranteed income, people immediately go into party lines or go into their political belief systems and they polarize and start arguing with each other. But if you start the discussion from the perspective of how can we save lives, and then through that discussion, you end up in a place where you're trying to stop people being in financial crisis, you end up in a different place. So that's just wanted to say that. And Steve, the next one's next steps, which you might want to run through.
Yes, absolutely. So, we're covering a lot of information here, and the report, which is on our website, thejordanlegacy.com, under the menu latest, is there for you to read, the further detail. I'm very much giving you highlights this evening, which will give you some context as to how in-depth the report is. But we'd like your feedback. What have been your key takeouts? By all means, leave them in the chat here. We will be saving the chat so we can review that as well. What are the key things you've taken away? What are the questions? What are the further ideas? This is an ongoing research project that we're certainly not at the end of that journey at all, nowhere near. So, any kind of feedback, whether that's through the Jordan Legacy website, through the Contact Us page, or through the chat here via LinkedIn, whatever means, we'll take all those ideas on board. Do you want to be involved? Do you want to contribute in any way through discussions? And who else do you think we should be involving? This could be organizations, it could be people of influence, or people, again, with lived experience. Remember, we're a very small organization, but we will manage this. We will take this on board and take your suggestions on board there as well. We are looking for opportunities to share this project, to share moving towards a zero suicide society and this future desired state map, and everything we're talking about here via speaking events, conferences, panel discussions, forums, through the public media. Can you help us in any way amplify this conversation about this report? Do you have connections you could introduce us to? Really, really important. We're going to be looking at the petition in a moment to get a Suicide Prevention Act implemented. How can you help us there? We will very quickly exhaust our own networks here at the Jordan Legacy. So we have to reach out to wider networks where people say, absolutely, we believe this should happen. How do we get out there? How can you help us achieve this? What kind of connections do you have? And again, the next steps is for us to continually update the Zero Suicide Society to say desired state map with your ongoing input. I think it's really important to stress we are facilitators of moving towards a zero suicide society. We don't have all the ideas. We've pulled this together through several months of conversations. So we're not saying that we have all the answers here, but with your input, we know we can continue to get the answers that we need to help save more lives. And what we want to be able to do then is to continually have more sessions like this. They might not be quite as lengthy, they might be, but any breakthroughs that we're having as we start to move forward with implementing actions from this report, we want to be able to share and update through future progress reports as well. So I think this is a good time, Paul, maybe to, I was a little premature before in bringing on a couple of people we've got joining us tonight on the call. So I'm going to try and manage this as best I can. We've got from the CEO of Elite Mind Academy, Evelina Zemanava-Chute, who joined us on Jordan Space, our radio show a few weeks ago. An incredible story coming from Lithuania, with not speaking any English, from a country where suicides are often considered as a normal event and a very high rate of suicide. So to hear her perspective, but then hear about the work she's doing in workplaces around well-being and mental health for employees and suicide prevention was fascinating. We'd like to get a few thoughts from Evelina in a moment. And also Bernie Hollywood, OBE, who's joining us, another guest who featured on Jordan Space some months ago. Bernie, again, it was a fascinating conversation, not long after returning from a solo crossing in the boat of Hope, some 3,500 miles across the Atlantic. But during his career in charity fundraising and supporting charities globally, has raised some £42 million for different charities. So I'm going to just press a few buttons here, Paul, and allow Evelina to talk, and hopefully do the same with Bernie. Yeah, I seem to be doing that. And
I'm just leaving you to push the button, Steve.
Okay, I'll ask. Bernie should be there. Evelina's vanished again, so let me just have a look. We should. I'll come to Bernie first for a moment, and just while I bring Evelina back. And Bernie, I'd be really interested to hear your views on what you've heard so far tonight, and get your take on what you've seen of the report so far.
Oh, thank you, Steve. I think the work that yourself and Steve has done is just quite mind-blowing, to be fair. It's obviously an area that we need to actually talk about and basically get engaged with, particularly in government, to get them on board. What you guys have done is just truly remarkable. And you know, my small campaign, which is very, very tiny, basically has got out to young children age 5 to 11 and age 12 to 18, and basically using the creative arts to engage in a conversation about how they feel inside their heads and hearts, to start that conversation about really sort of how they feel and get them to open up like they've never done before. The campaign, which has been running for over 3 years, has been hugely successful. And we've been to hundreds of high schools and primary schools around the United Kingdom, and used this particular format and process to have these conversations with the school children and the teachers, and it's had a remarkable effect. So it's spawned into many formats, and we've had a huge amount of support from some incredible creative people around the United Kingdom that have given us their time and resource for free.
I think what's really interesting, Bernie, thank you for sharing that, is that, you know, when people automatically think about suicide prevention within the education system, I think what automatically happens is people think it's about training suicide prevention or talking about suicide very specifically with children. But I'm just wondering what maybe in this particular area of the report, for example, if the things that stood out. But clearly what you're saying, and we know from the interview that we did with you as well, that it is about allowing children to be creative and express their emotions, and in doing so reduce the risk of them experiencing anxiety and depression later on in life. Was there anything from the report that specifically kind of stood out for you tonight that kind of you went, Yes, that is absolutely what should be happening.
Yeah, I think the initiative about having somebody responsible within government for suicide prevention really jumped out at me, and it's something that I'd like to champion alongside everybody else, alongside with yourself, to obviously take that to the next level. I think we do need to have a minister responsible for specifically for suicide prevention, and we need to have that as quickly as possible. It's incredible what we're doing in the background with our various campaigns and our various charities, but really to have a focus and to have funding for all of this great work that the charities and the campaigns are doing is really essential, that government come on board very quickly. And that Three Dads Walking have done an incredible job with that as well, with regards to raising it with Rishi Sunak and governments at top level. And obviously with the report that you've put together here with Steve, is just, again, a great step forward in evidencing really to government that, you know, we do need help, we do need resource, and we need to put these building blocks in place to actually start preventing suicides from occurring. So, you know, congratulations to you and Steve on a remarkable piece of work so far.
Thanks,
Yes.
Bernie. I just like to say that you know, every single piece is important. Every single piece, you know. So you know, people will talk about my little project, or you know, in my small area. Every single piece helps.
Totally agree. And thank you, Bernie. Evelina, hopefully we can. Thank you, Bernie. Hopefully we can hear from you, Evelina.
Hi, Steve. Hi, Paul.
Yeah, lovely to have you join us. Thank you again. Yeah, we obviously you know, interviewed you as well as part of this project here. Now it's kind of come together with everyone's contributions. What other areas that have particularly stood out for you from this evening and from reading the report that you'd like to comment on, really?
Yeah, definitely. I think for me, something that is very important is that whole language about how we speak about this, if we want to make that change. And, you know, starting with zero suicide and looking at that as that ultimate goal that we're working towards, that, you know, no matter how unrealistic or how utopian it might seem, but really having that importance in believing that, you know, we can make that difference, and every life matters, and therefore we shouldn't be aiming for anything less than zero. And including words of, you know, society in that, because I think it's so important that, you know, we have to have this ecosystemic approach, and we all can do something. But if we only operate in those small little pockets in these separate initiatives, it cannot make that collective impact that we would like. We really need that collective society level approach, tackling this from different angles. And again, talking about that kind of language, looking at it as you know, suicide as a means of death, and suicide is a solution. And if we're looking at it through that lens, then it opens up for us very different door to look at, this is solution to what, and therefore what are those other underlying problems that we need to be solving. And like you already mentioned before as well, that suicide prevention is not just necessarily, you know, going on stage and talking about suicide and death prevention. It's about that designing out suicide from the way how we operate in our society, in our education, how we talk to one another. And for me, obviously, societal impact on suicide can be very much illustrated by the statistics of suicide in my own country, Lithuania, right? So maybe for probably most of you who are listening here today will be aware of it, but the way suicide is measured is per numbers of death per 100,000 of population. And in UK, that number is around 7. It kind of fluctuates. I think at the moment, the latest statistics was like 7.9. So in comparison, in Lithuania, that number is 26.1. And at the highest number in 1995, which was just right after the independence years, and it was a lot of political turmoil, that number was 45.6. So obviously, when we look at that severity and the difference in the society in that specific country, I think there's a lot that can be learned around how exactly that society operates, and how exactly we could design out some of those processes and some of those problems that result in suicide as a solution. So definitely, I think my approach is very much about looking at how can we design out that out of society, and my work particularly, I choose to make that impact through organizational design and organizational well-being. If we are taking that human-centric approach, that design thinking, as you mentioned, ecosystemic thinking, which is very much embedded in how we approach well-being in organizations, then what this means that we are not looking at suicide per se, we're not looking at mental health and measuring that as a symptom level. But actually, what we are looking much deeper at these kind of unmet human needs, unmet diverse needs from diverse populations, and really understanding all of these complex factors that actually affect individuals. Some of the comments as well here from Suzanne, for example, we've been mentioned as well that, those issues are so complex, and yet when we look at solutions, they are very much superficial one way, and we are not taking enough research and energy to really digging deeper and understand those complex factors that affect individual experience to the point that suicide becomes a solution. So I think what I'm kind of taking out of this is really, well, first of all, just a big thank you for everything that you're doing, for this great awareness that you are raising. And I think if we really take that approach of society and collective impact and working together to overcome this, I think it is possible to design it out and to kind of, as a final little note. Yep. Yeah, sorry, Paul, go on.
No, I'm agreeing with you, and I'm just thinking that it's sparking off a few other thoughts in my mind, and it's related to some of the questions that we've got and some of the comments in the chat. If you don't mind me just coming in at this point, because in this project, we've brought in a number of people like yourself, Evelina, who have that sort of background in organizational change and transformational change and understand the system's dynamics. We have other people who obviously they don't work in that field, or that isn't, they're out there on the front line trying to support individuals, and they're out there trying to work in schools and so on. So everybody's a part of this solution. But in that kind of systemic change approach, when we actually, and Joanne's asked the question about, cracking this collaboration competition challenge, right? What we find is going on here is that the system is set up at the moment. It's set up to fail. It's set up as a scarcity model, and it's set up as a competitive model, and it's set up as a priority-based model. So what happens is that when people at national government level and national charity level often, and even some of the local partnerships, it happens with the local partnerships as well, the meetings often begin by somebody saying, well, obviously we've got limited resources. That's the very first thing they say. It's a scarcity mentality that obviously we've got limited resources. Therefore, we're going to spend the next 2 hours arguing about how we allocate those scarce resources. So that's not the way to get a collaboration model, to get the transformational change, to get the systemic change, to get the collaboration. So that has to be turned on its head. And people commented in some of the interviews about how things changed during the pandemic. Suddenly money was available that wasn't previously available. It was found from somewhere. Like, for instance, a directive went out to make sure that all homeless people, in March or April or something, April 2020, a directive went out to make sure that all homeless people had a roof over their head. And somehow people managed to find a way of getting all homeless people with a roof over their head. So we've got to challenge that. We've got to challenge this priority trap. As I said, some people will inevitably focus on priorities, but we've got to have everybody being a priority for someone. Suzanne, I noticed, putting comments in there about, obviously from her own experience, awful experience with the police custody suites. Interestingly, in West Yorkshire, when I saw the West Yorkshire suicide prevention plan, which is a good plan, really good plan, I noticed that their overall target for reducing the number of suicides was 10%. So I raised this. They're doing marvelous work, and I want to praise them. Fantastic, Jeff Parker, fantastic work, pulling everybody together. But I just queried, why was the target 10% in 5 years? The same old song. And they said that this year, with a new plan, they were going to go for a minimum of 10%. So it's had an upgrade from 10% to a minimum of 10%. That's the level of ambition. But interestingly, in the middle of the plan, it said the target for reducing the number of deaths in custody suites was 90%. So why would that be? Why would you say 10% overall, 90% reduction in custody suites? Well, that's because the people involved in putting that plan together didn't believe that they could reduce the overall numbers by more than 10%. But they believed that they could reduce the numbers of deaths in custody suites by 90%, because they could all think of practical things they could do, and Suzanne would be able to flesh out all the things that go wrong in custody suites and in police, as well as examples of where the police might do a good job as well. But, you know, everybody could think of practical steps that could be taken to reduce the number of deaths by 90%. So it's taking that thinking across a whole range of different other areas and parts of the system to get people believing it can be done and doing it.
Absolutely. I couldn't agree more. I think definitely in that design thinking approach, we can never start with limitations and why we can't do something and why something is not possible, because doing this, we are already limited by those resources. We should really be asking what's the goal, what is our ideal, and how we can get there given, you know, the circumstances and so on. And you know, human mind is very creative, and if we want better answers in life, we should first learn how to ask ourselves better questions. And we should never be asking, you know, if this possible or not, because we can come up with a list of excuses. We should ask, how is it possible, and what are all the different ways to overcome the obstacles that we are facing, and have that mindset towards that. And I think definitely, you know, this 10%, it's absolutely unacceptable. And of course, it's related to what is, you know, realistic, or what we can do. But it's like you're saying, Paul, it's so much more important to what do we really believe in, and how we really position that topic and awareness. So it is believable that everyone can believe that, you know, we can do something about it. And maybe 0 is not realistic, but we believe that we should be aiming for anything as close to that as we can, because again, you know, every life matters. And you know, 10% it's like sending a ship to the ocean and giving the instruction to the captain that, you know, in a case of the ship sinking, you only need to save 10% of people in order for you to be a captain of the next boat, right? It's absolutely unacceptable.
Well, I'm sorry, Evelyn, forgive me. Thank you so much for your thoughts on this. Clearly, a lot of things that have stood out. Really appreciate that. And talking of getting things done and doing things, I know, Paul, we'd like to cover the petition so everyone kind of understands.
I'll cover the petition, Steve. Just before that, again, I've been reading the chat. I've just had a chance to, I was listening to everything that Evelyn was saying. Just finally had a chance to just glance at the chat. And again, apologies, I haven't had a chance to read it properly. But I sense frustration in there from people saying, well, we've known this for years, or we've been talking about person-centered planning for years, and we've been thinking about this and doing this for years. We're also frustrated about this, but we've got to get together and do something about it. We've got to challenge it. We've got to have a kind of massive injection of common sense, you know, which I know doesn't often apply in some of our systems. But at the previous event, we talked a little bit briefly about the Golden Gate Bridge in San Francisco, a notorious spot for people taking their own lives, which was featured in Kevin Hines' film The Ripple Effect, after he survived jumping off the Golden Gate Bridge. And he talks about how he's on the bridge, he's walking up and down for about 45 minutes, he's on CCTV cameras, police officers can see him, but nobody actually stopped him jumping off. And the community looked at that and thought, well, how do we deal with this? How do we stop suicides? And they came up with this brilliant idea, brilliantly simple idea, putting a net under the bridge. So anybody who jumped off just jumped into the net and not to their death in the river below. So it's a brilliantly simple idea, to save masses and masses of lives. And it's finally come about after 87 years. Because of all the authorities and the bureaucracy and people wanting the bridge to look nice and all the other barriers that have been put away, it's taken 87 years to take an obvious practical action to save lives. So we've got to be much more challenging and powerful as a group to challenge some of these things. So that's me. I'm going to get off that particular soapbox now and talk about the petition. We'll go through the petition, and I think we'll be almost on time, but we'll keep an eye on any other questions that come in. If there's any other questions, we'll pick them up. We won't be able a chance to bring people in, but we'll try and answer any questions that come up. But shall I run through the petition, Steve?
Yeah, please, Paul. Yeah, let's do that. Okay.
So what we wanted to do was tell you the story of this petition, because it had an evolution. We were going through the report, we were picking off all of the practical actions that people had mentioned. And like I said earlier, there were things that we can do, we can all do, families can do, communities can do, businesses can do, organizations can do, sectors can do. We've had somebody I noticed from the construction sector in here tonight, which is great. You know, so all these things we can do. But there's things we need government to do. There's things we need Parliament to do. There's things we need in terms of a legal and regulatory framework, an accountability framework, an action learning, a national action learning framework. And this is how we're going to get the systems changed. So we thought, okay, we'll put together proposals for a Suicide Prevention Act. And we've studied around the world, you know, where there's some legislation in Canada, there's an act in Japan, there's South Australia has a Suicide Prevention Act. Not many of these countries have suicide prevention enshrined in legislation, but it does exist, and we've been able to look at it. And recently, we've had a remarkable breakthrough in Indonesia, where they've got suicide prevention now enshrined in their legislation and in their systems. And Steve and I met up with the guy who facilitated that entire process, so we know the story behind how they got there and the benefits of that for Indonesia. So we then thought petitions, and we thought, okay, the Three Dads example has been great. We've followed their story right from the beginning. We've been alongside them all the way. We followed them into Parliament. We watched the evidence hearing. We watched the Westminster Hall debate. We've seen them interact with MPs. They've got 150,000 signatures. We know this can be done, obviously with massive public profile. But then the Learn Network put forward their petition for a statutory duty of care for higher education institutions. And again, did a fantastic job, amazing job, 128,000 signatures, and we're learning from them as well, and got the evidence hearing. They got the debate. It was a slightly different evidence hearing and a slightly different debate for various reasons, but you know, we learned a lot from that experience. And even if they didn't support the actual specific proposal in there, the MPs, they supported the Three Dads. Most MPs supported the Three Dads broadly in terms of suicide education and the curriculum, but there were a few who were against the idea of a statutory duty of care for universities, and the universities were giving evidence and suggesting that they didn't need it, which we can't, no surprise that universities didn't think they needed it, and we're arguing about bureaucracy, red tape, etc. So there's pushback on that, but Lee and the team there had the opportunity to argue the case, and even if they don't get the statutory duty, it raised a number of issues about how to reduce suicides in universities, because there's around 100 university students take their own lives each year, and it also made the universities up their game as well. So the universities were giving evidence in Parliament and saying, oh, we're doing this, we're doing this, we're doing the other. And when they were challenged and said, okay, do you think that if a student has made a suicide attempt, that their parents should be told, their family should be told? Yes, we do. Well, why doesn't it happen now? Because it doesn't happen in lots of other cases. Oh, well, you know, and nod, and maybe it's because there should be a trusted person rather than a parent. But again, that debate is taking place in Parliament. So we thought we'll go down the petition route. So next slide, Steve. And what we did is we drafted a Suicide Prevention Act, monitoring and coordinated action learning to minimise suicides with that framework approach. Interestingly, the process was, this is the original draft that Steve and I had, the process was that we had to submit it, and we had to fit into their word count on the site. We'll come to that. And then it went off through the system to a civil servant at the other end, who we had some to and fro with. And he suggested some changes. And he came back, the first change he came back with, he changed the word minimise to reduce. And we said, no, minimise, put minimise back in. We want a petition and a system that minimises suicides, not reduces them. And reduces them could be 1, couldn't it? Or 10%. You know, we want 90%. We want to move towards 0. So put minimise in there. And then on the next slide, Steve, we started specifying these changes coming out of our proposal. So that we had this package of these things that we put together with the National Suicide Prevention Office, all government departments and agencies to have their zero suicide plans and do annual progress reports to the National Office, the mandatory multi-agency local area suicide prevention partnership. Our civil servant took out the word mandatory. Interesting, isn't it? Just how these subtle changes are within the system, enabling necessary data sharing. That's not breaching, as I said earlier, it's not breaching privacy or confidentiality. That's necessary data sharing of anonymized data or de-identified data. All public institutions, regulated industries or professions to have zero suicide frameworks. Again, it works. We know it's evidence-based, it works. Let's make sure it's right to the system. The mandatory suicide prevention. Now, again, I've seen comments in the chat here about, well, is it fair on GPs to expect GPs to do this or pharmacists? Or, well, we can get into that debate and we can have an argument about that. But most of the people we've interviewed believe that there should be mandatory suicide prevention training for all health professionals and all emergency service personnel and all teachers. And it's actually in teachers' own best interests to have this training because it helps them look after themselves. It helps them look after other teachers as well as the staff, the pupils and the community as a knock-on effect to community. And a lot of people gave examples like GPs, the training they get. Like every GP has mandatory training on CPR with annual checks and annual updates and audits. And when asked, how often do you use CPR? Last time was maybe 10 years ago. When was the last time somebody came in with a mental illness and was suicidal? Last week. So again, we've got to challenge the system in that respect. The impact assessments we've mentioned, I mean, there are various impact assessments that are used now, like environmental sustainability assessments. We're asking for a similar process, but for a suicide prevention impact assessment before new legislation or policy reviews. And interestingly, when we spoke to our contact at the Department of Health and Social Care about this kind of concept, this exact concept, he said that the department was actually favourably disposed, I love the language that civil servants use, favourably disposed to mental health impact assessments, but not suicide prevention impact assessments. So we know where we stand there. We know that we can push an open door in terms of mental health impact assessments, but we need suicide prevention. We need to push harder or find another way, friendly way of getting around this. Point 8, we put in our initial submission, and our civil servant took it out. And we said, why have you taken it out? And basically, the only conclusion we could come to was they didn't understand it. Didn't actually understand what that meant. All national and local suicide prevention initiatives to be informed by lived experience, which tells us a lot. We then had commitment to action on all factors contributing to suicides, because as we said earlier, it's multifaceted. That one was taken out, and partly because it's too general, and we're talking about an act, so we have to get into that, but we don't want to lose that in our final process in this. Ensuring appropriate support for those in suicidal crisis, community support. I mean, you all know what that kind of stuff means. Tackling loneliness and social isolation. There's actually the DCMS currently hosts a cross-departmental network to tackle loneliness and social isolation. It's already sitting there in parts of government, but it's not, again, it's not connected to the rest of it. Steve? We had all workplaces to meet standards for psychological safety and suicide prevention training. Again, our civil servant didn't quite struggling to get his head around that one. And we went for something more specific in the final version, which we'll come back to. We know that within the schools curriculum, the 3 dads have petitioned on, where we thought we'd keep it in there and keep the pressure on. Designing out suicide, the building regulations I've mentioned, and also making sure that counselling services and appropriate therapy services and support are available for all those who've experienced trauma and loss, including loss of suicide, because we know that they're at heightened risk, people bereaved by suicide. Now, we then took all of that, and Steve and I literally sat at the computer trying to fit this into the word count in the petition, parliamentary petition site, and we put those in. We took them forward with our civil servant until we agreed on a set of wording. And the one at the bottom there you'll see is RIDA reporting. So that's the statutory reporting of fatalities and serious injuries and near misses at work that go up to the Health and Safety Executive within the Health and Safety Act. Initially, our civil servant came back and said, oh, but suicides is already in there. Suicides already covered by the Health and Safety Act. We had to point out that suicides are specifically excluded from the Act, excluded from the RIDA reporting requirements, right? So obviously it went back in then. And when we've spoken to people in the construction sector and said, is there anything we can do to help you reduce the number of suicides in construction? That's one of the first things they say. Make that mandatory reporting for suicides, for suspected suicides, for major psychological injuries at work. And that will make a massive difference. So let's get behind this petition, for that alone, and hopefully all the other things above it. And there's 2 links to get to the petition. The top one is going via the Jordan Legacy website. The second one is direct to the petition site.
And just to add to that, Paul, as well, just rather than those links, trying to scribble down an unusual link there, is if you visit thejordanlegacy.com and go to the latest menu at the top of the page, you'll see the Action Research Project report in there, moving towards a Zero Suicide Society. And you will also see on that same page the petition, so the background to it and the links to it. So that's probably your easiest access rather than trying to jot down the links that are here.
Thanks, Steve. So next step, Steve's already run through these. I'll just emphasize a couple of points. Yes, we want feedback on the report. Yes, we're going to continue doing the action learning. On that third point, the Jordan Legacy speaking via events, conferences, panels, forums, and public media. Anything you can do to help us get onto platforms. You've seen us do this presentation, and we've got various forms of it. We can do a long version, do a short version. We can take the graphic 1-pager and do a very short version.
Was this not the long version, Paul?
Pardon?
Was this not the long version?
Let's not go there, Steve. Let's not go there. Now, we can do various forms of it tailored to audiences. The big conference season in this country is September, October. We've got World Suicide Prevention Day. We've got World Mental Health Day. There's a lot of events and conferences going on. We want to be on as many of those platforms as possible. If you're organising an event or you know somebody organising an event, please recommend that we are one of the speakers there, or running a workshop or something, or a panel discussion. And we want to get in front of MPs. We'll contact MPs individually, but obviously we'll need other people to contact their constituency MPs. We're looking for support and getting in front of all party parliamentary groups and things like that. And we've got several people who are offering to help us, but we'll do what we can there. Getting the Suicide Prevention Act implemented is a twofold process. It is getting signatures on the petition. 10,000 gets you an official response from the government, a written response, which can be supportive. It can oppose what you're suggesting. It can be ambivalent. Whichever it is, tends to get more signatures on the petition, we find. And 100,000 petition signatures with the appropriate sponsorship of MPs get you into Parliament, into those evidence hearings and debates. So we want you to sign the petition, encourage people to sign the petition, share it, urge people to fill it, to complete it, put it on websites, put it in newsletters, anything you can do. And also anything you do to get us in front of MPs or put us in touch with supportive MPs would be helpful. And then Steve's already mentioned these last two, but again, just very briefly, we're going to update that Zero Suicide, the updated desired state map with your further input. And also we're going to do progress reports in certain areas like education, health, workplace, etc. And we want people to join us in that, not just being interviewed, but maybe people who want to help do some interviews, or people want to write a chapter of a report, or people want to just join a task force, or something like. It won't be an ongoing thing. It'll be like a task and finish group, so it'll be time limited. But we're very keen to have you involved in that.
Good, thank you, Paul. But I know we're coming close to the end, but a couple of questions again. A question from Rosemary Ellis came from the National Suicide Prevention Alliance, and interested in what's come from our project and our discussions, Paul, and about the experiences of those living with suicidality, including those from the survivor movement. Something again we hear a lot, voices that they sometimes don't feel are heard.
I'm just reading that now, actually. I've only, Rosemary, forgive me, I've only had a chance to read that now. But no, it's a really good point. And I think that one of the things that we've learned through this process, because everything we've done has been based around kindness and compassion, and we're really exploring this area of kind campaigning and squeezing the stigma rather than smashing the stigma. We're really keen to change the language because it's very combative, it's very macho, it's very aggressive, it's about knocking doors down. And so we're trying to change that narrative. But in having those conversations, one of the things that's come out is that there is this kind of hierarchy within lived experience, and there are a small number of people with very big platforms and loud voices, and there's other people who don't get much of a look in, and there's people who don't open up about their experiences. And we've had criticism whenever I have an event, well, you're not including this person or this perspective. In the radio show, you must have somebody with this perspective. So we're trying to get there. We really are trying to get there over time. But when you get into people living with suicidality, and Steve and I get individual messages from people all the time, so we are in contact with them, but they don't want to be talking publicly about this stuff. People living with suicidality, people who say, I've got a brother or sister or a son who basically tried to kill themselves on a regular basis, and the clinicians have all said it's inevitable that they're going to die at some point. When you get into that sharp end of what is going on there, you do need to take a different approach, and we need to recognize that we're just scratching at the surface, and also that when these people do decide to speak about their experience, it's often difficult, not just because of experiences, but it's difficult because it's messy and complex, and it's not media friendly. Some people can stand on a stage and in 2 minutes kind of sum up their story and have the audience in the palm of their hands. And those people have still endured pain and suffering and loss and grief, and they have every right to tell their stories. And we want to support all people telling their stories. But for every one of them, there's hundreds out there who've got a messy, complex story that would take them half an hour to try and explain to somebody. We've got to invest time in those people.
Well, just as we come to the close, I think one more question that has actually come up a couple of times, actually, and our views on assisted suicide in the UK. Oh, yeah. And there's a risk, I suppose, that in looking to move towards a zero suicide society, we potentially collide with a lobby that's advocating for certain individuals to be given that choice, of course, especially when they've got chronic illness. Yeah,
I've been involved in assisted dying campaigns for 20 years, and I've sat in parliaments, including in Melbourne, which introduced the voluntary assisted dying bill after an all-night sitting. And I had to sit there and endure opposition MPs asking the most horrendous questions to try and filibuster, including, will this bill stop people from being gassed? Which at 10 o'clock at night in the Parliament building isn't a nice thing to hear. But we need to distinguish between voluntary assisted dying regimes and legislation and systems which are incredibly conservative, incredibly sensitive. They're designed for people with terminal illnesses. They're designed for people who've got 6 months to live usually, or for some illnesses it's 12 months, but usually it's 6 months. And it is a compassionate way of helping people who are in enormous pain to have a dignified death and to have their family around them as they die, and to either have physician-assisted dying or to have themselves administer the drugs under controlled circumstances with lots of checks and balances, at least two specialist physicians signing off on that, etc., etc. Right? And it stops people killing themselves on their own in horrendous circumstances, and then some member of the family finding them the next day. That's different to what we're doing here. We're talking about preventable suicides. We shouldn't use the term assisted suicide. It's wrong. It's factually incorrect. We shouldn't use it's assisted dying, and suicide is suicide. And people who try and stop that legislation mix up the language deliberately to obfuscate. But this is, you look back to our definition of a zero suicide society, it's a society that's willing to do, willing and able to do all it can to prevent all preventable suicides. All preventable suicides. Somebody who chooses to make an informed choice to take their own life under assisted dying to relieve themselves of pain and terminal illness is not a preventable suicide.
Good, thank you, Paul. And I'm sure we've got many more questions. But as we come to the end, really, I just wanted to Paul, firstly, thank you for taking definitely the lion's share of this evening and getting across the points in your own inimitable style and detail and background and knowledge. And just want to thank you personally. Paul joined me very early on in this journey, and Paul, I was jokingly described himself as my right-hand man here. Without Paul's knowledge and experience here, we wouldn't be close to be achieving a lot of things that we feel we are at the Jordan Legacy, and we're told we are as well, which is nice. So really just final word really from us, so thank you for joining us tonight, and we do need your support. I think let's be very honest about it. We are a community interest company, a CIC. We're small, we're three of us. We rely on financial donations from companies and individuals, and without those, we wouldn't be able to continue. And some months are kind of by the skin of our teeth, that's for sure. If you feel that you or anyone you know might be interested and willing to and able, of course, to support this particular project, the QR code that's on the screen will go to a Just Giving page that is specifically to help us raise funds to continue with this project. And I'll just leave that slide up on the screen. And as I say, we will be saving the chat. We will send you an email with a recording of tonight's event as well. I know a lot of people who registered were unable for one reason or another to join us tonight, so they will get that copy. So we're kind of hoping a lot more people will see this. Feel free to share that link as well with anyone you think would find it valuable. But just, final word to say thank you all very much for sticking with us late in the evening, and in some parts of the world, very late into the night and early morning as well. We really appreciate you taking the time